Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 520 of our pharmacotherapy series, which majors in renal dialysis. The first case reads, ROW, a 55-year-old man with stage 4 chronic kidney disease as a result of poorly controlled hypertension, presents to the renal clinic for reassessment of his kidney function. He is 70 inches tall and weighs 70 kilograms. Since his last visit 3 months ago, his creatinine clearance, abbreviated as CLCR, has decreased from 22 to 12 milliliters per minute, and the BUN has increased to 89 milligrams per deciliter. The serum potassium is 4.8 milliequivalents per liter and the bicarbonate is 17 milliequivalents per liter. He has selected hemodialysis as his form of therapy until a suitable donor kidney is available, and is expected to begin dialysis within the next 1 to 3 months. When he begins dialysis, he will be dialyzed 3 times a week for 4 hours each treatment, using a Fresenius F160 dialyzer, with blood and dialysate flows of 400 and 500 milliliters per minute, respectively, and bicarbonate containing dialysate. So my first question to you reads, what characteristics of the Fresenius F160 dialyzer make it a good choice for patient ROW? What determines the composition of the dialysate? The correct response is, the Fresenius dialyzer is a high-flux dialyzer as described previously. This polysulfone membrane is a synthetic membrane with larger pore sizes than conventional cellulose membranes. The F160 has a KUF, that is the ultrafiltration coefficient, which is the volume of water removed per millimeter of mercury across the membrane per hour of dialysis, of 45 milliliters per millimeter of mercury per hour, indicating a high ultrafiltration capability. An in vitro K0 a urea of 1064, a measure of dialyzer efficiency for urea removal, urea clearance of 266 milliliters per minute at a blood flow of 300 milliliters per minute, and a surface area of 1.5 meters squared. This information can be located in the product literature from the manufacturer or summary tables from common dialysis references. These data are used to individualize the dialysis prescription for a patient. I would now like to briefly comment on dialysate composition. Dialysate composition usually is standardized within certain limits of electrolyte content, yet allows for individualization as necessary. Water is obtained through the public water system, which then undergoes treatment by reverse osmosis, followed by ion exchange with activated charcoal to remove contaminants, such as aluminum, copper, and chloramines, as well as bacteria and endotoxins. The dialysate solution does not require sterilization because the dialysis membrane separates the blood and dialysate compartments. Nevertheless, pyrogen reactions may occur, and a greater risk may exist with high-flux membranes because of the increased pore size. The final dialysate solution is prepared in the dialysis machine by proportioning a dialysate concentrate with the purified water, resulting in a final product. By adjusting electrolyte concentration in the dialysate, the efficiency of dialysis for particular chemicals can be manipulated. For example, if the patient is hyperkalemic, the dialysate contains a low concentration of potassium for diffusion of potassium from blood into dialysate. On the other hand, if the patient is normokalemic at the start of dialysis, the potassium concentration of the dialysate is set at a normal physiologic concentration to minimize flux of this electrolyte across the membrane. If the concentration of a solute is higher in the dialysate than in the blood, the net movement will be into the blood, not out. Metabolic acidosis, which is associated with end-stage renal disease because of an inability to excrete the daily obligatory load of acid, is controlled with the addition of bicarbonate buffer to the dialysate solution. Before delivery, dialysate is heated to 37 degrees Celsius to maintain body temperature and avoid hemolysis, which can occur with excessive heating. Dialysate is also deaerated under vacuum to remove dissolved air from the solution. To achieve a sufficient blood flow for dialysis, ROW must have a vascular site for chronic access. So my next question to you reads, what are the options for chronic vascular access in ROW? A permanent vascular access site provides easy access to high blood flow, which cannot be achieved through routine venipuncture of superficial veins. Different types of vascular access are available. Arteriovenous, abbreviated as AV, fistula made by joining an artery and vein in the arm, arteriovenous graft, a soft tube made of polytetrafluoroethylene to join an artery and vein in the arm, and a double lumen or tunneled, cuffed catheter placed in a large vein, usually in the neck. Arteriovenous fistulas and grafts are placed in the non-dominant arm. Ideal vascular access delivers blood flow rates necessary for chronic hemodialysis, has a long period of use, and has a low rate of complications, e.g., infection, stenosis, thrombosis, aneurysm, and limb ischemia. An arteriovenous fistula is created surgically by subcutaneous anastomosis of an artery to an adjacent vein. The arteriovenous fistula may not be suitable for patients with poor vasculature, such as elderly patients or those with diabetes mellitus, atherosclerosis, or small vessels. The KDOQI guidelines for vascular access advocate placement of a fistula at the location of the wrist, that is radial cephalic, or secondarily the elbow, that is brachial cephalic, as the preferred vascular access sites. Once created, vascular access requires time to mature before it can be used for hemodialysis. The fistula should preferably be created 3 to 4 months before its intended use to allow the vein to mature. The graft can be used soon after insertion, although 2 weeks will allow for healing at the anastomosis sites and may prolong patency. Arteriovenous fistulas fail to mature at a higher rate than grafts. However, grafts require 4-fold higher interventions per year, elective angioplasty, thrombectomy, or surgical revision, to maintain long-term patency for hemodialysis. Central venous catheters are discouraged for chronic vascular access because of high rates of infection and occlusion. During the dialysis procedure, one needle or catheter is placed into the fistula site to deliver blood to the dialyzer. This is often referred to as the arterial line to the dialyzer. Blood exiting the dialyzer is returned back to the patient's fistula site through a second catheter and needle, referred to as the venous line, from the dialyzer. If patient ROW has adequate vasculature, a fistula should be created for chronic access. Vascular access is critical for chronic hemodialysis and often has been labeled the Achilles heel of dialysis therapy. Complications associated with vascular access are a significant problem in patients having chronic hemodialysis. The most common is thrombosis, usually the result of venous stenosis. If not treated, thromboses will result in loss of the access. Access-related complications are a major cause of hospitalization and, therefore, attention to these problems is important both clinically and economically. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 521.